Bismillah Rahman Rahim. My name is Dr. Muhammad Naseem Shirzad, and today I am trying to cover male related infertility or male infertility. So, number first is the definition of infertility. Infertility is defined by the inability of a sexually active, non-contraceptive couples to achieve spontaneous pregnancy within 12 months. Now it is divided into two types. One is primary infertility and the other is secondary infertility. Primary infertility means that the couple who had never been pregnant and never had a child. And the secondary infertility, those infertile couple who have been able to achieve pregnancy at least once before. If she has given birth previously a child and now infertile, that is called secondary. But if a patient is not even given a single time she is not a pregnant, that is called primary infertility. Sometimes there is an interchangeable word subfertile. So currently still in guideline the word infertility is using, but it's thinking that infertility is used for those which cannot be fertile by any means, while subfertile are those which can be fertile by some means like by artificial reproductive techniques. But still in guideline the word infertility is present, so we will be talking on the infertility, not will be using the word subfertility. So, after understanding this concept of subfertility, infertility, primary and secondary infertility, the next step is the history and proper history of the patient. And this history need a lot of detail. You need to ask a lot of detail from a patient, like you need to ask the previous evaluation or treatment they have taken for infertility. You should to ask for the duration of the infertility, that how much long and how many times they have tried to conceive. You should to ask from the coital timing, the frequency, any lubrication they are using, the febrile illness, if the patient is having febrile illness in 1 to 3 months, or recent some stressful condition, if the patient is suffering from some stressful condition that can derange the semen, and that can again affecting the infertility. If the patient is having some genital urinary infection, ask about proper sexual history like sexually transmitted disease, erection, ejaculation, and regarding the libido and orgasm, that should be properly asked. Any hormone related treatment like for gynecomastia or any hot flashes or loss of libido or loss of facial and body hair, if they have taken any treatment, that should be asked. Then the age of the puberty should be asked, that at which state is that, in order to exclude the precox puberty and may indicate some adrenogenital syndrome. Asked about the cryptorchidism or testicular torsion history. Asked from a patient regarding the trauma to the genital or pelvis or even perineum. Any current medical illness if the patient is suffering from, like diabetes, cystic fibrosis, etc. Ask about the past surgical history of vasectomy, vasostomy, reversal, and inguinal hernia repair. Asked about the gonadotoxin exposure like radiation therapy, chemotherapy, pesticide. These all affecting infertility. Asks about the social history of the patient, as the patient is taking tobacco, drug abuse, occupational exposure. Then ask the family history of the patient. So all these should be asked in history. After that, the physical examination is important. Better to examine the genitalia, better to examine all the secondary sexual characteristic of the patient. Secondary sexual characteristic properly should to be assessed. Evidence, if there is any evidence of endocrine dysfunction, better to assess, examine the gynecomastia. Assess the patient for any neurological problem like visual field, anal sphincter tone, neuropathy, and the overall look of the patient, skin pigmentation. So these should be checked in the physical examination. Now, for the better understanding of these causes and their treatment and their investigation, better to have some concept of the male reproductive physiology like the hypothalamic pituitary gonadal axis. This is important, where the gonadotropin releasing hormone, which we are also called luteinizing hormone releasing hormone, that is releasing from the hypothalamus in a pulsatile manner and detect on the pituitary gland to produce FSH and LH. Now this FSH and LH coming into the testis and working there. So now let's discuss the basic of the testes. In testis there are two types of component. One is the seminiferous tubule and the other is the interstitial tissue. Seminiferous tubule is comprised more than 70 to 80%, while the interstitial tissue comprise only 20 to 30%. And this seminiferous tubules having a straight tubules that forming retitesti, then apparent tubules, and then forming the epididymis. And epididymis is the area where there is a high sperm mortality achieved by the sperm at this level. Then it forming the vas deferens, and then vas deferens combining with the seminal vesicle, and this seminal vesicle combination with vas deferens is called ejaculatory duct, and this ejaculatory duct then opening into the posterior urethra in the flora of vero mentanum. This seminiferous tubule is lined by the Sartori cell, and this Sartori cell help in the process of spermatozoa. So what happening? The FSH which is produced by the pituitary gland that acting upon the Sartori cell, and that Sartori cell performing the spermatogenesis. The second main component is the interstitial tissue, and that is forming 20 to 30%. And the interstitial tissue lie the Leydig cell, and that Leydig cell are responsible for testosterone production from hypothalamus gonadotropin releasing hormone that acting on the pituitary gland producing follicle FSH and LH, FSH acting on the Sartori cell to perform spermatogenesis, while the LH act on the Leydig cell and that's producing testosterone. So these three component, hypothalamus or cranial part, the testicular part, and the post testicular part. That's why the causes will be divided into pre-testicular cause, testicular causes, and post-testicular causes. So we will be discussing these things in detail. So the causes of male infertility for easy of understanding is pre-testicular, testicular, and post-testicular. As our initial investigation in many of the patient is semen analysis, so when we advising the patient semen analysis and that showing us the azoospermia, then we dividing it into two, obstructive azoospermia and non-obstructive azoospermia. Non-obstructive azoospermia are those which are pre-testicular and testicular, and obstructive azoospermia is the one which is post-testicular. So as we have divided that on the basis of the semen analysis into obstructive and non-obstructive azoospermia, but the next investigation in our line is the hormonal profile, and in hormonal profile we are advising FSH level and testosterone level, and this can differentiate again the non-obstructive azoospermia classification as there are problem in the cranium or the problem in the testis. For example, if a patient is producing a lot of FSH or the patient FSH is very high, it means there is a problem in the testis, and we call it the hypergonadotropic hypogonadism, or we can say that there is a primary testicular palaver, or we can say it is a primary hypogonadism. So primary hypogonadism, or we also call it primary testicular palaver, or we can also call it is the hypergonadotropic hypogonadism, means there is a problem in the testis because the brain or the cranium or the pituitary gland producing FSH, but the testis is not responding. So after primary problem of the testis, the next problem can be in the cranium. And when the FSH level is low or there is no FSH at all, we call that as the secondary hypogonadism, or we can also say that this is hypogonadotropic hypogonadism. It means there is some problem going on the pituitary gland. Maybe the patient is having hyperprolactinemia, or the patient is having gonadotropin deficiency. So that's why in these patients, when having secondary hypogonadism, better to advise them MRI brain. The third scenario, if the FSH level is normal. What does it mean? If FSH level is normal, it means that the brain is working, the testis is working, so there is a problem in delivery. The other pre-testicular causes of non-obstructive azoospermia, The patient may be having Klinefelter syndrome. The patient can have Y chromosome deletion. The patient can having diabetes mellitus. The patient may be having erectile dysfunction or impotency, or the patient may be using the various causes which we have discussed, is like the drug, SSRI. These all can lead into pretesticular causes of azoospermia. Now, quickly review the testicular causes of azoospermia. That may be there is a Cortengler syndrome or immotile cilia present. The patient may be having cryptorchidism, or there may be some acquired condition like the patient may be having infection or mumps, or the patient may be having varicocele. The patient can have Sertoli cell only syndrome, or the patient may be having primary testicular palaver, or the patient can have Wood syndrome or oligoestenoteratospermia. So these are the testicular causes of hypo. Now let's discuss the post-testicular causes of infertility or obstructive azoospermia. So the cause of obstructive azoospermia, there may be problem in the obstruction of the afferent duct of the testis. I mean there is obstruction in intratesticular level. Maybe there is a congenitally absence of pons deferens, or maybe the patient is having Young syndrome, the acquired condition that affecting the epididymis. Maybe the patient having tuberculosis or gonorrhea. The surgical history of the patient can also lead into the obstructive azoospermia, like herniorrhapy, vasectomy, and testicular torsion. These can also lead into the other causes include the ejaculatory palaver, or the patient is having retrograde ejaculation, or the patient is having hypospadias, or the patient is having bladder neck surgery. So one another important point, that if a patient is having secondary hypogonadism, we are also advising them, these patient, the prolactin level, and that should be 2 measurement, and if it is a high, then we will go for MRI brain. So we have divided the investigation. First, we advise the seminal analysis, and that gave us that the patient is having obstructive or non-obstructive azoospermia. If the patient is having non-obstructive azoospermia, then we have advised them the hormonal profile, and in hormonal profile, if it is the if the FSH level is low, then we are going to perform the prolactin level, and if it is a high, then we will go for MRI brain. Now, if the FSH level is normal, then we can assess the testicular volume, and that can be measured with a Prader archidometer, or we can also using the testicular ultrasound. Now let's start the management of these 3 causes, like the problem in the cranium, the problem in the testis, and the problem in the delivery, means the obstructive azoospermia. So if there is a problem, I mean if there is a secondary hypogonadism, we can treat those patients by the induction of spermatogenesis, and we can induce the spermatogenesis by giving the patient beta HCG or human chorionic gonadotropin, or we can give the recombinant FSH, or we can give them as a combination of beta HCG and recombinant FSH. So when we are talking about the gonadotropin means FSH. So that's why FSH increasing the spermatogenesis, and it is advisable for a patient with secondary hypogonadism. Don't use testosterone therapy for the treatment of male infertility, and upper dopamine agonists like bromocriptine in a patient who having prolactinemia in order to improve the sperm quality. If a patient is using any type of anabolic steroid, better to withdraw all that anabolic hormone. So the starting dose of human chorionic gonadotropin to stimulate spermatogenesis, that is 250 international unit, twice weekly is suggested, and if the testosterone level reach to a normal level, then it can be increased up to 2000 international unit twice a weekly, and then we will repeat the semen analysis after 3 months. So now let's discuss the surgical option for obstructive azoospermia. You know, the obstructive azoospermia can be treated on the basis of the level of obstruction. Like if the obstruction is present at the level of epididymis, then we can go for epididymovasostomy. And if a patient is having obstruction at the level of vas deferens, then we can go for vasovasostomy. And if the patient is having obstruction at the level of ejaculatory duct, then we can go for TURED, means transurethral resection of ejaculatory duct. So these based on the at the level of obstruction. Now let's discuss the sperm retrieval technique, and this sperm retrieval technique should be performed along with reconstructive surgery. And if a patient is don't want any surgical repair, we can go for only for sperm retrieval technique. Or if the patient not preparing to undertake any type of surgical construction, and the couple want to go for intracytoplasmic sperm injection, then they can go just for sperm retrieval. And the sperm retrieval technique include the microsurgical epididymal sperm aspiration, we call it MISA, or we can also go for TZ, means the testicular sperm extraction. And we can go for some percutaneous technique like percutaneous testicular sperm aspiration or epididymal sperm aspiration percutaneously. So these can be used for sperm retrieval. Now regarding the non-obstructive azoospermia that of because of testicular failures. So number first principle and according to guideline is to confirm a diagnosis of non-obstructive azoospermia in two consecutive semen analysis when no sperm are found after centrifugation. Perform a comprehensive assessment including detailed medical history, hormonal profile, genetic test, and scrotal ultrasound to investigate the underlying etiology and associated comorbidity in patients with non-obstructive azoospermia. The genetic counseling is mandatory in a couple having genetic abnormality prior to going for any assisted reproductive technology. Perform surgery for sperm retrieval in a man who are candidate for assisted reproductive technique. It means that sperm retrieval should be followed by assisted reproductive technology, commonly by the intracytoplasmic sperm injection. And don't perform surgery for sperm retrieval in a patient with complete sperm depletion or microdeletion, since there is no zero chance of sperm retrieval in that cases. So there is no need to go even for sperm retrieval in these condition. Don't perform biopsy like fine needle aspiration and testicular sperm aspiration in a patient with non-obstructive azoospermia. So it is clear that if a patient is having non-obstructive azoospermia, there is no need for percutaneous testicular aspiration or fine needle aspiration by mapping technique, and that is not recommended in clinical practice. Use microdissection TISA, but when we are using the testicular extraction of the sperm, that should be done with the microdissection by opening by open technique, not percutaneous technique, not recommended. And don't use medical therapy like hormonal stimulation in a patient with non-obstructive azoospermia and hypergonadotropic hypogonadism before any type of testicular sperm extraction. So to summarize it, all patients with primary testicular failure should be advised to go for sperm retrieval along with artificial assisted reproductive technology like intracytoplasmic sperm injection. Number second, don't perform sperm retrieval in a patient having micro deletion, because there is a zero chance to retrieve any type of sperm from this patient. There is no need of any sort of fine needle aspiration, I means percutaneous procedure for biopsy or sperm aspiration in a patient with non-obstructive azoospermia. The only thing is the microdissection testicular sperm extraction by open technique. This is the most recommended technique for non-obstructive azoospermia. There is no need of any hormonal stimulation before performing TZ or testicular sperm extraction. Now let's discuss the various methods for sperm retrieval, and we can retrieve the sperm from epididymis or testes. So let's discuss first the epididymal sperm retrieval. For epididymis, we will be always using the word aspiration. We can't extract the sperm from epididymis, but we will only can aspirate. And there are two way. One is microsurgical and the other is percutaneous. So always prefer the microsurgical than percutaneous in any type of sperm retrieval. Don't go for percutaneous method. So for epididymis, we can use microsurgical epididymal sperm aspiration, which is called the MESA, or we can go for percutaneous epididymal sperm aspiration. To summarize, always goes for with open or microsurgical. Don't go for percutaneous. In epididymis, there is no option of extraction, only option is aspiration. Now let's discuss the retrieval technique from the testis. Same, in testis we have both option, that of aspiration and that of extraction. Always go for extraction, I means the open technique, and don't go for percutaneous technique. So for testicular, we are using the testicular sperm extraction, which is an open technique, which is the prepper technique, and the other is the percutaneous testicular sperm aspiration. This is not advisable and not performed. So to summarize the testicular sperm retrieval, the better one is always is the MESA. MESI mean microsurgical testicular sperm extraction. Don't go for PISA, means the percutaneous sperm. Now let's summarize the testicular sperm retrieval technique. The better is always the MESI. MESI means microsurgical testicular sperm extraction. Don't go for PISA, means percutaneous testicular sperm aspiration. So this is the best method to go for microsurgical sperm extraction, testicular sperm extraction technique. Now let's discuss the assisted reproductive technique, and it can be defined as any treatment that is deal with the means of conception other than the vaginal intercourse. We call it as the assisted reproductive technique, and there are various types. The most common is the intrauterine insemination. The second is the in vitro fertilization, and the third is the intracytoplasmic sperm injection. Now let's have some concept of artificial insemination. Artificial insemination means the manual placement of a semen in the reproductive tract of the female by a method other than the natural mating. Like the best example of artificial insemination is that of intrauterine insemination. It is the simplest and least expensive method of assisted reproductive technique, and during this procedure a small catheter is placed through the cervical os to deliver the sperm directly into the uterus, thus bypassing the cervical barriers. Upon sperm are proceed in the laboratory to enrich the motile fraction before intrauterine insemination, and the indication for these intrauterine insemination may be cervical picture, coital problem, unexplained fertility. So in these conditions we are going for an intrauterine insemination. The second is the in vitro fertilization. In vitro fertilization means when a woman egg are removed from the ovary and that is mixed with the sperm in laboratory, and once fertilized the embryo are then placed into the woman uterus. The third is the intracytoplasmic sperm injection. Intracytoplasmic sperm injection is a specialized form of in vitro fertilization in true sense that is used primarily for the treatment of severe case of male factor infertility, and it involves the injection of the single sperm directly into